Hi, everybody. It is 1 p.m. in Paris, 12 p.m. in London, 7 a.m. in New York, and 7 p.m. in Beijing. A very warm welcome to all of you. This is the IACH, the International Academy for Clinical Hematology, around the globe and across the hematology field. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And it is my great pleasure today to deliver this webinar dedicated to multiple myeloma, a summary of the highlights from the latest ASCO and EHA 2024 annual meetings. As you may guess, multiple myeloma is always on the podium. This is like a very fascinating disease where almost every month, every week, we would see a lot of advances, and the outcome of multiple myeloma patient is significantly improving thanks to this amazing global cooperation and collaboration between all stakeholders trying to bring the best treatments to patient. So these are my disclosures. I will structure this webinar into the usual sections: the newly diagnosed multiple myeloma, traditional chapters, transplant eligible and transplant ineligible. Then we'll move on to the relapse refractory setting, and I'll distinguish the small molecules, antibody-drug conjugates, bispecific antibodies, and immune therapies in general. When it comes to the transplant eligible patient, we keep on talking, I think, and highlighting the results of the so-called Perseus phase 3 randomized trial that was published earlier 6 months ago in the New England Journal of Medicine on behalf of the European Myeloma Network. You can see here the design of this trial. Very nice, relatively straightforward design. Classical VRD, bortezomib, lenalidomide, dexamethasone, compared to a quadruplet, daratumumab, VRD, followed by high-dose melphalan, consolidation, and maintenance. The traditional maintenance was lenalidomide alone in the VRD arm, and the doublet maintenance was daratumumab and lenalidomide in the quadruplet arm. There is also guidance of the maintenance with Dara and Len based on MRD, but we don't have these results yet. And you may remember the original presentation and publication about the primary endpoint. Absolutely terrific results, highlighting an 84% progression-free survival at 4 years versus 68%. So a clear benefit in favor of this full treatment package consisting of a quadruplet followed by transplant, followed by consolidation, but also doublet maintenance. What we have seen at the latest EHA meeting is shown here, and this is about the evaluation of MRD negativity and comparing between these two arms. You can appreciate that, first of all, in the quadruplet arm, we have a doubling of the rate of deep MRD negativity, including the most sensitive threshold, namely 10-6. And what is really important is that the MRD negativity keeps on increasing during time. And actually, during the doublet maintenance, we had approximately 30% of the patients who were able to improve their MRD negativity. And this is an important piece of information highlighting the importance of continuous therapy, but probably also the importance of this doublet maintenance, which is something transformative. This is something new because usually we would rely on single agent lenalidomide. And MRD negativity deepen over time. Patient becoming MRD negative are increasing over time, but it's also about sustained MRD negativity. And we have significantly more sustained MRD negativity in the quadruplet arm. And on the bottom right hand of the slide, you can see the MRD conversion rate for patients who remained MRD positive at the end of consolidation. So all of this will translate into a significant advantage in terms of progression-free survival according to the MRD status. Again, the most important threshold, 10-6. And you can see these beautiful curves for those patients who are achieving 10-6 sustained MRD negativity. And these patients are really enjoying a long progression-free survival. So clearly an important message from this trial, quadruplet induction Dara-VRd is the standard of care. And there is definitely a tendency and a clear suggestion that doublet maintenance would be the right thing to do. And this is reflected here in the conclusions from the investigators at time of presentation of these data. Another important highlight of EHA was the long-term follow-up update of the Cassiopeia trial, which was a collaboration between the IFM group and the Hoven group. It was initially published by Dr. Moreau and colleagues. And here we have seen a long-term follow-up update of this trial, which actually was also published simultaneously in the Lancet Oncology a couple of weeks ago. You can see the design of the trial. This is a trial which has actually established the proof of concept about quadruplet induction. And in this case, it was Daratumumab plus VTD, bortezomib, thalidomide, dexamethasone. But this trial had also a second randomization looking into maintenance with Daratumumab single agent. And I think it was the first trial to test the proof of concept of using an anti-CD38 monoclonal antibody for maintenance. The long-term follow-up is showing, again, a very significant progression-free survival in favor of the quadruplet arm, as shown here on the red curve. When you look to the PFS from the second randomization, again, there is a clear benefit, and the median follow-up is very long and decent in favor of the Daratumumab maintenance. Obviously, this wasn't randomized against the standard of care lenalidomide, because when the trial started, lenalidomide wasn't the standard of care. It has become, was approved later on. But still, I think it's a very elegant demonstration about the value of Daratumumab maintenance. It's also an interesting demonstration about the value of using daratumumab both before transplant but also after transplant, because there was an initial debate questioning whether we still need daratumumab post-transplant if patients have received it before transplant. Here, it is clear that there is a benefit for using daratumumab before and after transplant. When it comes to PFS2, and this could be a sort of a surrogate marker of the overall survival, again, you can see a significant improvement of the second so-called PFS2 from second randomization. So you can appreciate now that taking into consideration the Cassiopeia trial, the Perseus trial, but also the Griffin trial published earlier, the phase 2 randomized Griffin trial from the US, all of these trials are highlighting the value and importance of quadruplet induction, but also likely maintenance based on daratumumab plus lenalidomide. We do have also roughly similar data, although it is not approved in this setting, with the other anti-CD38 monoclonal antibody. This is the German HD7 phase 3 randomized trial looking into isatuximab VRD compared to VRD, followed by auto, then randomization between isatuximab lenalidomide versus lenalidomide. And we have similar non-randomized design with isatuximab KRD in the high-risk patient in the concept trial that was published in the JCO earlier this year. During the EHA meeting, we had an update about the results of this HD7 trial. And the key message is there is a clear advantage in terms of response rates in favor of the quadruplet arm. But again, it highlights now the high rate of MRD negativity, also deep MRD negativity, that we are able to achieve with this kind of quadruplet induction prior to transplant, but also the doublet maintenance, again, highlighting the importance of an anti-CD38 plus lenalidomide maintenance. Last but not least, regarding the transplant eligible population, I thought to highlight this phase 1 open label single arm study from China using a dual targeting against BCMA and CD19, a so-called fast CAR. You can manufacture this CAR in a few days. It's a phase 1, so only 22 patients. All of them are high risk, either based on cytogenetics, based on extramedullary disease, but also other features. And the investigators were brave enough to test frontline after VRD induction, a couple of cycles of VRD, then apheresis, to deliver this dual targeting BCMA and CD19 CAR T cell, because we know very well that these high-risk patients are truly an unmet need despite the great advances we have seen. It's a proof of concept about using, I think, CAR T cells in the frontline setting, and it is quite reassuring to observe that the majority of the patient, almost 100% actually, will become MRD negative. And obviously, this is important given the fact that we have now in Europe and the US an ongoing important trial, namely CARTITUDE-6 trial, randomizing auto against cilta-cel, an excellent CAR T cell construct. And this trial is ongoing. It's not focused on the high-risk patient. It's all comers, I would say, eligible to transplant, but definitely the CAR T cells are likely to make it into the front line at some point. And here you can see the conclusion of our Chinese colleagues highlighting the benefit, but also excellent safety of using this dual CAR T cell construct. That was the story of the transplant eligible patient. We have also seen very convincing, beautiful data in the transplant ineligible patient. And for the sake of introduction, I would like to highlight to all of you that in the last 4 or 5 years or so, the standard of care and the best results in the elderly non-transplant eligible population were achieved with daratumumab, lenalidomide, and dexamethasone, thanks to this phase 3 randomized MAIA trial already published and communicated several times by Dr. Facon and colleagues. And you can appreciate that with a long-term follow-up, the 7-year overall survival rate was significantly higher and in favor of the Dara-Lendex arm. And these are, I would say, very robust results, long-term follow-up, but also because 1/3 of these patients were above age 75. So clearly, Dara-Lendex is the basis for what we currently do and the foundation to transform the prognosis of elderly myeloma. In parallel, a few years ago, and still in some countries today, we know that VRD is another standard of care. And that was the rationale behind actually this phase 3 randomized trial, so-called Imroze trial, that was presented at ASCO, presented at EHA at the Presidential Symposium, published simultaneously in the New England Journal of Medicine by Dr. Facon and colleague. And the design of this trial is very straightforward. The control arm used the classical VRD, bortezomib, lenalidomide, dexamethasone, and you can see the design of the schedule of the administration of these drugs and dosage. And it was compared to an anti-CD38, namely isatuximab, plus VRD. VRD was followed by Lendex maintenance, and the quadruplet ESA-VRD was followed by ESA-RD maintenance. And what we can see, obviously, it's a phase 3 randomized international trial. The characteristics of the patient were balanced in both arms. I would draw your attention to the median age of 72, so truly an old population. But on the other hand, all of these patients are considered as fit, and the upper age limit in this trial was age 80. The other characteristics are similar to what you would expect from this population in the real life. And here is the primary endpoint with with 5 years of median follow-up, which is very important, I think, when it comes to a population with a median age of 72. There is a clear advantage of the quadruplet ESA-VRD, PFS rate at 60 months, at 5 years, 63%, median not reached, versus an excellent, actually, control arm achieving a median PFS of 54 months at 5 years. And we are able to achieve such long PFS because the response rates were higher with the quadruplet. So you can see it's a similar story to the transplant eligible population, but here there's no transplant. And also you have deep MRD negativity but also sustained MRD negativity, for instance, at 12 months. And one thing you may wish to discuss, we had to wait here 5 years to get the results of this trial. And if we were able to evaluate the endpoint, the primary endpoint based on MRD, we would have actually reached this conclusion, the same conclusion of the superiority of the quadruplet at 1 year. So having MRD as an endpoint, and just opening a parenthesis here, is important for bringing rapidly new regimens, new drugs into the field. Looking into the different subgroups with all the pro and cons regarding the power or the number of patients, actually all patients are likely to benefit from the quadruplet ESA VRD. And these are the conclusions of the authors, clearly showing that the Imroze trial has established a quadruplet based on isatuximab VRD as a new standard of care in the elderly but fit population. And I think it's very important to insist on the fit population with an excellent safety issue. And obviously, that was compared to VRD. So the question is, how does isatuximab VRD look like compared to Lendex plus an anti-CD38, something equivalent to Dara-Lendex? And this was the spirit of the IFM benefit trial presented by Dr. Leleu, published simultaneously in Nature Medicine, and it has compared a control arm with isatuximab RD, something similar to Dara-Lendex. At least we can speculate that is a similar, an anti-CD38 plus lenalidomide and dexamethasone, like in the Maya trial. And then in the experimental arm, adding bortezomib, ISA VRD. There are slight differences in the dosage and schedule of the drugs between benefit and Imroze. I will not go into the details for the sake of time, but phase 3 randomized trial, the characteristics of the patient are comparable, beaten age 73, so really an old population. And the primary endpoint here was MRD at 18 months. And there is a clear benefit for the quadruplet arm. And actually, the results were already there at 12 months. So again, it looks like assessing MRD negativity at 1.5 years in this population can give you a clear picture, a clear direction on where to go. And this is true in the different subgroup analysis. And here is the conclusion of the authors. In line with Imroze, this benefit trial is demonstrating that a quadruplet with ISA VRD, when compared to a triplet like VRD or to a triplet like isatuximab and RD, is proving to be superior and should be recommended for those patients who are non-transplant eligible or not willing to proceed to transplant, but who are fit. Obviously, there is an overlap because, you know, in Persus trial, in the transplant eligible, the upper age limit was 70. And here, so you have a sort of a between age 65 and 70, where actually we have a proof of concept, whether in the transplant eligible and non-transplant eligible, about the value of quadruplet therapy. And maybe the question is not anymore about transplant versus no transplant, but quadruplet for everybody. And then you can sneak in the transplant whenever possible. And in the elderly population, triplet for everybody, at least as a foundation for all patients, including the frail patient, because we can give Dara-Lendex with an excellent safety profile and efficacy. And then looking into those fit patients where you would like to upgrade with a quadruplet. What about now the relapsed refractory setting? And again, the congresses brought a lot of novel information. Not only about bispecific and CAR T cells, but also about the other small molecules, but also some very new exciting data regarding actually the antibody-drug conjugate, because you may have noticed that we had the presentation and release of the DREAM7 and DREAM8 trial, which have rejuvenated actually the use of belantamab, the anti-BCMA. But first, let me show you some data about Selinexor, an XPO1 inhibitor. This is a copy of the poster. I know it's very busy to read, so I'm not asking you guys to read it. It's just to emphasize that for those patients who are not able or eligible to receive an immune therapy with CAR T cells or bispecific, we should not forget that we have a drug like Selinexor, an XPO1 inhibitor, which can be combined with IMiDs or proteasome inhibitors, and it's already approved with proteasome inhibitor, Selinexor plus bortezomib dexamethasone. And actually, it is now more and more used in many places where it is available. And when we look to some updates of the results, you can appreciate that there are likely regional differences. But I wanted to emphasize that it can be a good option. Even if you'd like to use CAR T cells, it could be a bridging options. So please keep it in mind, because some patient may need this kind of options. DREAM7. So you probably remember the story of belantamab, which was approved at some point based on single-arm phase 2 single-agent DREAM3 trial, I think. And then it was discontinued because of a negative trial against Pomdex. And the big novelty from the last meetings is about the DREAM7 trial, which was published in the New England Journal of Medicine simultaneously. And this is a very important, in my opinion, trial, randomized phase 3 trial, comparing head-to-head, actually, Daraveldex, Daratumumab, bortezomib, dexamethasone, the regimen that was validated and approved thanks to the Castor trial. You may remember this from a few years ago, published by Dr. Palumbo and colleagues. And the head-to-head comparison was against belantamab combined to bortezomib, dexamethasone, BVD. A quick reminder, belantamab is an antibody-drug conjugate targeting BCMA. So it's the usual, I would say, target, but in an antibody-drug conjugate. So mechanism of action completely different compared to what we know about the immune therapies like bispecific targeting BCMA or CAR T cells targeting BCMA. You can see the design of the trial. In the Daraveldex, they received Dara monotherapy continuously, and in the belantamab arm, they received belantamab monotherapy after cycle 9. And one figure can summarize it all, and this is exactly what you can see here in the intention to treat population. The combination of belantamab, bortezomib, dexamethasone led to a significant increase in PFS compared to Daraveldex. Obviously, you may question whether Daraveldex is the ideal regimen for relapse, but it is a valid control arm, and you can appreciate at 3 years, we have a median of more than 36 months of PFS, which is definitely a significant and very important result in the relapse setting. 60% improvement compared to the control arm. Of course, immediately people will raise the question about the toxicity of belantamab, because one key feature or key issue we face with this antibody-drug conjugate is the incidence of keratitis and its impact on the eye, which at some point can alter the quality of life. So here we have some good news. Obviously, the ocular adverse events occurred more frequently with belantamab Veldex as expected, but actually they were, for most of the time, reversible, and with good management, especially lengthening the cycles, the duration of the cycles, actually you can overcome this complication, and that provide you with a very practical, useful, effective regimen where you would give 3 or 4 cycles per year for these patients. So clearly, you can see here the conclusion of the authors about DREAM7, where we have a PFS benefit, an overall survival benefit, deep responses, and it is likely that now we are able to overcome this issue of ocular toxicity, which is reversible, but also manageable with dose modification. And then at the end of the day, you had very few treatment discontinuations, only 9%. And there are no difference in terms of global quality of life as measured by the famous ERTC QLTC30 scale. So please watch out to the advent of belantamab Veldex, especially that we have another trial presented at EHA by Dr. Dimopoulos, first author Dr. Trudel from Canada. This is a DREAM8. And this trial has looked into a different partner, actually, for belantamab, namely Pomdex. So BPD, belantamab Pomdex, experimental arm, compared to a very good standard of care, well-established, the PVD standard of care, bortezomib, pomalidomide, dexamethasone. And this was established and approved thanks to this so-called Optimism trial. Again, very beautiful data in favor of the belantamab arm. So it looks like, guys, that targeting BCMA is more effective than actually targeting CD38 or using a combination like PVD. So these are really important information, and we know the importance of BCMA for the proliferation and the survival of the malignant plasma cells. And this is reflected here in these results, showing again a 48% improvement in favor of the belantamab pomalidomide dexamethasone arm. We don't have yet final overall survival data, but you can look into this in an indirect manner thanks to the PFS2. And this is looking into the treatments that were delivered to these patients who are progressing during the course of this trial. You can see the list here. I will not go through the details for the sake of time. But again, PFS2 is in favor of the belantamab Pomdex arm. So in another word, targeting BCMA early in the relapse setting is not inducing more resistance, and you are also able to salvage these patients later. So based on DREAM7 and now DREAM8, actually, I believe, and this is what I mentioned in my introduction, that belantamab has been rejuvenated in the relapse refractory setting. And I think this is important because this is an important family of drugs, the antibody-drug conjugates. The mechanism of action is different from our other BCMA targeting agents, and obviously it will find its place in the overall landscape and will fulfill some unmet needs. Let me move now into the different bispecifics. And the immunotherapy based on bispecific antibodies is really fascinating. It's a fantastic in vivo immune therapy. And this is about targeting a tumor antigen and the CD3 T cells, bringing them together, establishing a sort of an immune synapse, and then allowing the T cells to proliferate to become cytotoxic, and that will lead to the cytotoxicity rapid effect. And we are very fortunate already having 2 bispecific antibodies directed against BCMA being approved, namely teclistamab, the first to be approved, elranatamab, targeting also BCMA. We have also a bispecific antibody targeting GPRC5D, namely talquetamab. And during the last EHA and ASCO meetings, we've seen some very nice novel data with cevostamab, which is a bispecific antibody targeting CD3, but also BCMA. So a totally different target. And I have chosen this communication by Dr. Kumar, Shaji Kumar, and colleagues because they have focused on those patients who received prior antibody-drug conjugates against BCMA or prior CAR T cells against BCMA. Because obviously these days, at time of relapse, when they are available, almost all patients are receiving, if they are not receiving CAR T cells, but they are receiving clearly anti-BCMA bispecific antibodies. But if these patients progress, if they have received belantamab, if they have received CAR T cell, how can we salvage them? And this is the importance of this cevostamab analysis, where you can see the features of these patients. The median lines of therapy is 6. Median time since last anti-BCMA therapy was 5. And I would consider these results are really very robust, very powerful. If you have received a prior CAR T cell against BCMA, you can still expect 73% of overall response, including more than 55% of VGPR. If you have received an antibody-drug conjugate, you still have 60% of overall response rate and more than 20% of VGPR. Looking into adverse event, it looks like that targeting FcRH5 is not really inducing severe or unexpected side effects. CRS were mild and manageable, neurotoxicity frequency low, only 1 case of severe neurotoxicity. When it comes to infections, there are some opportunistic infections, viral reactivations, bacterial, but maybe it's not a comparative randomized trial, but maybe it is less than what you would expect with a BCMA targeting agent. So this is an important, I would say, option for those patients who are failing an anti-BCMA therapy. The other data we have seen during EHA I had the pleasure to update the long-term survival of the magnetism MM3 trial. We published this last year in Nature Medicine. And with long-term follow-up, you can appreciate that at 2 years, we're looking now around 88% of probability of duration of response for those patients who are in more than a CR. And this is 67% in those patients who with an overall response. And if you look to the progression-free survival, again, the median PFS is 17.2 months with elranatamab. And in those patients achieving CR, we're almost at 91% at 2 years. And that gives you an overall survival, a median overall survival of more than 2 years, 24.6 months. So reassuring results about the use of elranatamab as a BCMA targeting bispecific antibody. We have also updated the data from the French Compassionate Use Program. And again, the results are in line with what we see in the MM3 registration phase 2 trial, although the population was harder to treat, more advanced. But the important piece of information is about the safety. And it looks like that with implementation of prophylaxis and preventive measures, but also immunoglobulin supplementation, you can significantly reduce the infectious complications. We have also some great news with teclistamab, which was the first anti-BCMA bispecific to be approved. And teclistamab works very well. And we have here in this poster presented at EHA a specific subgroup analysis on those patients treated in the Majestic-1 study. This is the phase 2 registration trial, and looking into those patients with high-risk features. And by high-risk features, the authors defined penta-drug refractoriness, high-risk cytogenetics, very old patient above age 75, high tumor burden, extramedullary disease, and ISS stage 3. The good news, using teclistamab in penta-drug refractory in high-risk cytogenetics, but also very old patient above age 75, is leading to a response rate similar to what you would see in the overall population. And I think it's very important to emphasize the capacity, our ability to deliver bispecific antibodies into old but also frail patients, and this is important. Then you have this group of high tumor burden, extramedullary disease, ISS stage 3. You may view the results as the glass is half empty or half full. And we have exactly a similar pattern with elranatamab. So there's no difference among the different bispecific antibodies targeting BCMA. Those patients with extramedullary disease, high risk stage 3 ISS, or high tumor burden, actually are going to respond less. They are going to respond, but this is lower to the rest of the population. So in another word, we really need to design new approaches for these patients. And we are more and more discussing, for instance, the use of conventional chemotherapy to debulk the disease before starting bispecific antibodies. The other good news we had during EHA and ASCO were from the Monumental 1 talquetamab study. So I kindly remind you, talquetamab is the first bispecific antibody approved directed against GPRC5D. And this is another important tumor antigen, highly expressed on the plasma cells. I will not go into the details of the trial, but with long-term follow-up, actually, we do have a confirmation about the efficacy, but also the safety of using talquetamab. But also, another important piece of information, because there were some, and there are still some concerns about the toxicity of talquetamab, especially when it comes to dysgeusia, mucositis, toxicity on skin and nails. And obviously with dysgeusia, mucositis, patients are losing weight. And now there is a learning curve, and you can see that the side effect and the weight loss actually is mainly seen, observed in the beginning, maybe first 2 cycles, but then things are improving with longer treatment. And I think there will be a learning curve, and actually lengthening the cycles of talquetamab is likely to help solving this problem. Similar story to belantamab, and the eye toxicity. The other, I think, good news is that it is likely, and it has to do with the function of the target, and you cannot compare BCMA and GPRC5D. BCMA, when you target BCMA, you are eradicating the normal plasma cells, so you're reducing significantly the secretion of immunoglobulins. It is likely that with talquetamab, especially with a twice-monthly dosage, we are reducing the incidence of severe infections. So really, very good news, and the advent of talquetamab targeting GPRC5D is most welcome in the field, because obviously we need to work on these different targets if we would like to give different lines of treatment. Obviously, the $1 billion question is about what is the right sequence. Should we target first BCMA, then GPRC5D, then FCRH5, or ABC, BCA, CBA? I don't know. Today, the common belief is that maybe targeting BCMA should be started first, and then we will look into GPRC5D or FCRH5. But this is not, we don't have evidence-based data to support this. It's just expert opinion in general and common belief based on the role of these molecules and their mechanism of action. And speaking about bispecific, actually, bispecifics are really a fascinating platform. So it's a true immunotherapy, and you can modulate, play with this platform almost in an indefinite number of constructs. And one important aspect is to play on the affinity of the binding domain. You can play on the affinity of the CD3 binding domain for the T cell, but you can also play on the affinity to the tumor antigen domain. And if you play on this, you may end up with different constructs. And we don't know yet what's the value of this or this. This is why I think we like and we appreciate that many companies are developing different constructs. And during the EHA meeting, we had the results of this ABV383 BCMA CD3 bispecific antibody. And you can appreciate that one specific feature of this bispecific, it's an IgG-like bispecific design, plus a bivalent BCMA Fab. So it's different compared to the other bispecifics. And this ABBV-383 is uniquely designed with 2 BCMA binding domains, and it has a low affinity for CD3. And another important feature, which is, I think, crucial for the patient or the organization of care, is the dosing frequency, which is every 3 or 4 weeks. The other bispecifics, teclistamab, elranatamab, were originally approved on a weekly basis. Then we would give twice monthly later. But here, from the beginning, you have longer cycle dosing frequency, and it is likely decreasing the incidence of side effects, especially severe infections, but also the CRS and ICANS. And despite this, actually, you can still achieve an excellent safety profile. And it has to do clearly with this monthly administration. Here you can see the overall response rate, 65%. So similar to what we have seen with the other BCMA bispecific. Median PFS, 11.8 months. Also, for instance, similar to teclistamab. Of course, I'm not trying to compare across trials, but these numbers look like quite similar, which is quite reassuring. The other player in this field is this other bispecific called linvoseltamab. And this is a human BCMA CD3 targeting bispecific. It has a different design. It was presented by Dr. Susan Lynch during EHA, but it was just published, I think, a couple of weeks ago in JCO. A decent number of patients, 117 patients, median age 70 up to age 91. So highlighting, as I mentioned, that we can give bispecific really to old and even frail patients. Median prior lines of therapy is 5, similar what we have seen when magnetism MM3 and in Majestic 1, but also the ABBV-383 trial. And 80% were at least triple refractory and 26% at least pentarefractory, and 84% were refractory to the last line of therapy. And here is the objective response rate, 71%. So including more than 46%, more than a CR, and that would give you a very elegant PFS curve, where the median PFS is not yet reached, and the probability of maintaining response at 1 year was 78% for all responders and 92% for all those patients with more than CR. And if you look to the high-risk subgroups, the response rates are lower for extramedullary disease, for instance, 58%. High-risk cytogenetics, 67%, probably similar. And so you can see there is some similarities among all of these bispecific, but maybe there are subtle differences when it comes to the profile of safety, but also to the efficacy. Obviously, we cannot draw any final conclusions because we don't have head-to-head comparison, and also these are single-arm trials. But I think it is important to have access to these different bispecifics, and it is crucial that we would be able to use all of them. Again, the message in terms of infections, because of the T-cell exhaustion when using bispecific, because of the immunocompromised status of these myeloma patients, because of the inhibition of the secretion of immunoglobulins, it's important to use all the preventive measures with cotrimoxazole, antibacterial antibiotics, amoxicillin, for instance, antiviral, valacyclovir, and immunoglobulin supplementation. But it is likely that we will not use these bispecific alone as single agent forever. And we can improve their efficacy, especially we can reduce T-cell exhaustion. And we do have already some proof of concept, at least in vitro, about this feasibility, especially if we rely on the easy-to-use IMiDs like lenalidomide, pomalidomide, but maybe also the upcoming cell modes like iberdomide or mezigdomide. And this is exactly what has been done, actually, in this nice monumental 2 trial, where talquetamab, the GPRC5D targeting bispecific, was combined actually with pomalidomide. And here the idea by using pomalidomide is not about, in my opinion, to use the anti-myeloma activity of IMiDs, but rather the immunostimulatory, immunomodulatory activity. And it looks like it works. Again, it's not randomized, but definitely you can see a higher percentage of an overall objective response rate. So a very nice proof of concept about the possibility to combine bispecifics with other agents, especially, for instance, agents that allow to improve T-cell function. And this is leading, you can see here, the response rate, which are deepening over time, and they are likely improving the PFS of these patients. So really very fascinating proof of concept. So based on all this, I believe that we are really in a scenario where we see that long-term follow-up of the trials using bispecific is showing some long-lasting deep responses, no additional toxicities. And I can even say that based on the real world, our own practice, the toxicity profile is improving over time. There is a learning curve. I think we need to pay attention to these new constructs, new formats of bispecific, the high affinity binding to BCMA, low affinity binding to CD3, half-life extension. All of these tweaking, I would say, might improve the efficacy and safety. But you don't need high technology actually to improve the efficacy and safety. For instance, looking into fixed duration or treatment with extended treatment-free interval would probably allow the recovery of the T-cell fitness and reducing the risk of T-cell exhaustion, but also a tumor target, a tumor antigen loss. And last but not least, combinations are likely to come, and you may be aware that we have now trials testing bispecifics into earlier lines of therapies. With this, I'd like to thank you all for your attention. I know that there are many new data, but I had to make a selection. I hope you have enjoyed it, and I can see already an incredible number of questions that I'll try to do my best to handle. So we have a question about in a resource-limited setting, is there a value in adding daratumumab during consolidation and maintenance when you have used VRD induction? Well, it's very difficult to answer. I do appreciate that we need to find solutions for all situations. All I can say that daratumumab and targeting anti-CD38 is crucial in the natural history of multiple myeloma. And at some point, the patient need to receive an anti-CD38 monoclonal antibody like daratumumab as soon as possible. We do have a question from Dr. Hamad. What about bortezomib as maintenance therapy? Well, historically, especially in the high-risk cytogenetics, there were studies looking into combination of bortezomib and lenalidomide maintenance. However, I don't believe that is the most optimal way of doing maintenance. And I believe today that if we have to do doublet maintenance, it's likely daratumumab and lenalidomide that, in my opinion, are the best options. We have another question about evaluation of MRD, because we speak a lot of MRD, and it's a relevant question. How do we evaluate MRD? Well, either NGS, next generation sequencing, or next generation flow. But of course, imaging is important. I will not go into the details, but obviously these two techniques are valid. If you want to achieve a 10-6 threshold, obviously NGS, the clonoSEQ technology is likely easier. Dr. Francisco Di Raimondo is asking me that in DREAM-7, there is also ocular toxicity even in the control arm. Is it because the study is dealing with elderly patient, or there is an ocular toxicity of daratumumab? I don't believe there is a concern about ocular toxicity of daratumumab. I believe it's simply when you do randomized control trial, you are able to detect signals that you usually miss sometimes in the real life. And this is why we pay attention, and it is mandatory if you want to bring a drug into routine use to do these prospective and monitored trial. That is my explanation. And obviously, the older are the patient, the more issues and toxicities you will see. Here we have a question about whether we should use bispecifics at time of relapse or at time of MRD positivity. This is a brilliant and timely question. Well, today, teclistamab, elranatamab, talquetamab are approved for those patients who are triple class exposed or triple class refractory, and they are used at time of relapse. Today, we're not yet at the level when we can do preemptive relapse therapy, and based on MRD, probably this is what we do in other hematological diseases. In lymphoma, if you see a positive PET scan, you would start a new therapy, or you would modify your treatment approach. We're not yet there in myeloma, but I think this is wise, an important comment. Dr. Iram Saeed is asking, why adding pomalidomide to bispecific if patients have already been on it or progressed on it? Very important question. This is why I insisted on the fact that we're not using, at least in the Monumental 2 trial assessing talquetamab plus pomalidomide, we're not using pomalidomide as an anti-myeloma drug, but rather to allow the recovery of the T-cell fitness as immunostimulatory drug. Dr. James Nyamtaga is asking about the combination of elranatamab VRD for induction. Well, the short answer is that I don't know these results, and of course, we cannot comment on this. All I can say, that bispecifics, whether talquetamab, whether belantamab, whether teclistamab, whether cevostamab, all of them at some point will move into the frontline or earlier lines of therapy. We have another question about using CAR T cells after bispecific. I must confess, I don't know. The very few available data suggests that we should rather use CAR T cells whenever possible first and then bispecific. But this story can be different if we're using different targets. This claim is valid when using an anti-BCMA CAR T cell and an anti-BCMA bispecific. But I think it's a very rapidly moving target. One question, I didn't discuss CAR T cells, only one abstract in the front line, but there is this, I have a question here about reports regarding secondary T cell lymphomas following CAR T therapy. Well, it's a controversy today. I think based on the advanced age of myeloma patient, I'm not today worried. We need, of course, longer follow-up, but I'm not worried about this issue of T cell lymphoma. And of course, I refer you to the different publication in this field. I can see that time is running, guys. I hope you have enjoyed this post-Congress webinar regarding multiple myeloma. We do have many other activities. So thank you for being loyal to these educational activities brought to you by the ICH around the globe and across the hematology field. See you soon.